adherent to the medication she had been discharged on a week earlier. So because we kept looking for a precipitant and being a lot of things were against the things we were thinking, we thought maybe this is just a progressing underlying decompensated liver cirrhosis. At this point, we still don't know the etiology. Yeah. So we went ahead to think of some differential diagnoses. Because we have jaundice and pruritus, we are thinking anything that can cause a cholestatic picture and give us this presentation. So we are thinking of things like primary biliary cholangitis, primary sclerosing cholangitis. However, these things are usually not as acute as we saw in this patient. She was diagnosed a month ago, treated for 2 weeks, improved, and then she comes back a week later in a worse state than she was discharged in. So these are usually more chronic. They're still over years. And also, we didn't have abdominal pain. We didn't have things like weight loss, like things that would point to a chronic picture were sort of ruled out at this point. And then we had a diagnosis, a possible differential of pancreatic pathology still because of the jaundice, the pruritus, with also cirrhosis and hepatic encephalopathy. But again, no abdominal pain, no weight loss. We were still looking for a possible other differential. So we looked at gallbladder pathology for the same reasons, for and against. Hepatocellular carcinoma, for it, we thought, oh, this rapid decompensation could be maybe hepatocellular carcinoma because we know that they progress really fast, but also 1 month was such a short time. Then because of just the altered mentation, confusion, disorientation, we thought maybe she had a meningitis, which would lead us to like a septic picture causing her decompensation. However, there was no fever reported, no headache, no neck stiffness, like no clear symptoms of meningitis. So at this point, we are really still looking for a possible differential diagnosis because there is a lot against the ones we are thinking about. So let's see if examination findings will help us get a better diagnosis. Thank you.
Thank you so much, the presenters. Okay. Thank you so much, the presenters. We are going to have a series of questions and we delve into the discussion today before we proceed to the examination findings. Unfortunately, we'll have to project your voice today because we don't have the microphones that are movable. Thank you. So I will hear from the undergraduates, then the postgraduates, and later the teachers. We shall take at most 4 questions. Thank you. The undergraduates. Okay, let's hear from Dr. Sarah, then Dr. Baronji.
Thank you very much. I have to mention that after patient management was improving. And I got to giving the role treatment, and then in that regard, we improve the drug. Given that she's given has to become a scientific teacher for jaundice or potential injury. We just still have that very up and we have
Thank you so much, Dr. Sarah. Yes, Dr. Barunji.
Thank you so much. Sometimes using a possible or anything that
thank you, Dr. Barunji. Let's have Dr. Harriet.
Thank you so much. I just want to let you know that especially with the studies of PCA, about hand was mixed up of the presenting complete. Again, show butterfly. The most recent admissions and that sickness that the patient is coming with, and then how we separate that and go to the customer. Maybe you did a bit of gravity in that question.
Thank you so much. We shall have Dr. Mubarak and they first answer that set of questions and then we shall progress. Yes, Dr. Mubarak.
As at the error, looking at your diagnosis premise, it's quite about how we that then your
Dr. Mtenyo, I invite you, but for all those speaking, like I said, we don't have a mic today. Try as much as possible to project your voices so that we can all keep part of the discussion.
Thank you for your wonderful questions. Some of them I was unable to hear them clearly, but I'll address the ones I've been able to pick. Dr. Mubarak, you asked about how we came to the conclusion of hepatic encephalopathy grade 3. Yes, it's very true that most times you have to go further and first examine. However, we were mainly leaning towards the history of the confusion and the incoherent speech. So she definitely isn't in a stupor. She definitely isn't in a coma, but she's definitely confused. That's why we leaned more towards grade 3 hepatic encephalopathy. Sarah asked about the possibility of ursodeoxycholic acid and other medications helping her improve initially, and I didn't get the last part yet well, but it's all a possibility. Like we've said, at this point, we are also still working out our possibilities. We're like, maybe the medications helped her improve. Maybe we are missing something. And that is why I said, maybe if we examine more and investigate more, we can get more answers at this point. Someone mentioned the possibility of bile cast nephropathy as a differential. Yes, we have certain features that could suggest that we have a nephropathy going on. But again, we still have to investigate to solidify some of those things. Thank you. Any question I've not addressed?
If there is any other set of questions, you can raise up your hand and she's going to come in with the other set of questions to address the issue of the order of presentation from Dr. Harriet. So we shall take 2 more questions and then we'll proceed. So Dr. Kawamba Imelda and then Dr. Bijo Isaac. Thank you. Okay. Yes, Isaac.
it's in one presentation.
Okay, Dr. Mtenyo, let's address those and then Dr. Senabulia comes in with our examination findings.
Thank you again, Isaac, for your excellent question. We felt the need to mention the no autoimmune diseases in history because, as you can see, our presentation of this patient really is a lot about, we talked about the pancreas, we talked about the gallbladder and that area, and we know a lot of autoimmune conditions that could lead to this presentation affect that area. That's why we felt the need to mention it. The first question I didn't get clearly. Kindly repeat your question. Okay. So for that, we were not able to really establish because she showed up acutely. She said she had been unwell for 3 days before she presented at that place.
All right, thank you so much for that question. Maybe just to clarify. So before she presented to the specialist peripheral facility, she had been unwell for about a month. So when she came here, she had already been diagnosed. By the time we saw her on the 5th of August, she had been diagnosed with liver cirrhosis. And when we did the liver panels and all the others, it was more of like cholestatic liver pattern injury because the R factor and the APRI score. The APRI score typically was, if I'm to be right, it was between, it was initially 4.6 something, but later on, I think Sarah asked why she improved with also deoxycholic acid and the prednisolone. So it could be because they were thinking, could it be cholestatic liver injury? In this case, could it be primary biliary cholangitis, where we know that deoxycholic acid could actually be the first line. Maybe that could explain the reason why there was that improvement, but we shall see later on. Then I think Isaac asked about autoimmune diseases. So we know, like Charity said, the hepatobiliary system has some autoimmune conditions that are associated with it. For instance, patients with autoimmune hepatitis have a high propensity of getting atrophic, chronic atrophic gastritis, which is really autoimmune, and sometimes also they can have pancreatic pathology affecting the beta islets of Langerhans. So those are patients who come in with type 1 diabetes, but all these were ruled out. Sometimes they may also have rheumatological conditions, especially rheumatoid arthritis, ankylosing spondylitis, and others. And we have seen case reports written up on this, but all those, we exhaustively ruled them out. Thank you. Then I think there was a question about, so that's why you saw our past medical history was a bit divergent from what we usually see in the mini rounds. We sort of like try to circle it out because we wanted you to understand the chronology of events from when this patient was seen from a peripheral facility, first seen in Mulago, and now comes back to us in a week after the initial therapy. That could have improved. Maybe we're right on what we're thinking. So wanted to just bring that out. So you can forgive us because ideally you're not supposed to do that, but we wanted to make sure that the team is well adherent in terms of understanding how the chronology of events was. Thank you. Then I think, is there any other question? Yes, Prof.
So did you explore the use of alcohol?
Absolutely, yes. So we did explore very widely, and this patient, fortunately, did not have any sort of herbal drug use, yes. Yeah. Prof, yes. What was she? Yes, it was really mild because that's why we're confused, because patients who you think could typically have primary biliary cholangitis or primary sclerosing cholangitis, you think that one of the biggest things is that they come with a long-standing history of pruritus because they have cholestasis. But for our case, the pruritus was, to be honest, in the 1 month before she presented to the peripheral facility, there was actually no pruritus. So the pruritus just came in that probably 2 weeks following initiation of deoxycholic acid. So we're thinking, oh, cholestyramine also didn't help. So maybe there could be something more, which we shall see later on. Thank you. Yeah. Absolutely. So that was the thinking, because the differential diagnosis list could go on and on. But Wilson's disease typically, oh, okay, yes. Okay, sorry, Prof. Sorry, Prof. Yeah. Yeah. Yeah, so the reason why we did not specifically think of Wilson's disease, because Wilson's disease, I mean, it's also abnormalities in copper metabolism, but typically a patient will come in with neuropsychiatric complications on top of the liver disease sections. So they didn't have any sort of anxiety, depression, and all that. Exactly. But in terms of the psychiatric manifestations, because one study was done, and sort of like compared the neurological versus psychiatric complication, and to see that most of patients with Wilson's disease will tend to have probably a long-standing history of psychiatric, maybe anxiety, depression, before they actually come in with full-blown liver cirrhosis. Then hemochromatosis, that's why you saw on our integumentary system examination, there were no really body color changes, because in hemochromatosis, you would expect a bronze kind of like skin discoloration on top of the, depending on also on other systemic complications that can come, because the iron deposition could be in the heart, so they could come with full-blown cardiac manifestations, which in this patient, we did not think. They could also have, especially diabetes, because of iron deposition in the pancreas. So the differential diagnosis list could go on, but we try to just link up the fact that this patient already had liver cirrhosis that was diagnosed, and I wanted to just narrow it down. Thank you.
Thank you so much, Regan. We are going to proceed to the next phase of the discussion. It is getting interesting and heated. We shall have the examination findings, and then we shall have the investigations, and then we shall have a more comprehensive discussion at the end. Get your questions ready, be ready for the discussion, because this is quite an interesting case. So let's have Dr. Fenabu. Thank you.
Thank you very much. Good morning. Mzenawe Robert, SHO-YA1. I'm going to take us through examination findings. Just before we proceed, hemochromatosis, it tends to present in the 50s for women because they tend to bleed every month. So they're a bit protected. When we examined our patient, she was speaking, so the air was intact. The breathing, she had a normal work of breathing. However, the respiratory rate was slightly high, the higher end of normal at 20, saturating well on room air, and the heart sounds were normal. Saturation, the BP was normal, as you can see, map of greater than 65 with a pulse rate of 93. However, the shock index was high. Disability, the RBS was normal. Pupils were 3 millimeters, equal and reactive to light, with a GCS of 12, localizing pain, and a verbal of 3. In exposure, that's when we exposed her for examination. There was nothing significant in the exposure. Okay, so on an exam, she was a young female in fair nutritional status with normal hair distribution, sick looking, a febrile to touch with moderate scale jaundice and moderate conjunctival pallor. She was moderately dehydrated with grade 2 pitting edema, no finger clubbing, no nail abnormalities noted, no palmar erythema, and no lymphadenopathy or Dupuytren's contracture. And she had no ecchymosis or petechiae. The weight was 82 kilograms and height of 173 with a BMI 25.24. On abdominal exam, it was moderately distended, moving with respiration, non-tender with no visible collaterals or spider name or caput medusa. She had a hepatomegaly of 2 finger breasts below the costal margin and a splenomegaly of about 5 finger breasts below the costal margin with a positive shifting downwards. The bowel sounds were slightly reduced at 2 with no venous harm. She had grade 3 hemorrhoids on digitory exam, which were painful but not bleeding. So on systemic examination, the GCS was 12. We said the localization was, she had localizing pain and the verbal was at 3. Pupils were equal at 3 millimeters bilaterally. The neck was soft with a negative canning sign and no focal neurological deficits or cranial nerve abnormalities noted. Respiratory exam, she was not in distress, though the respiratory rate was on the upper end of normal. Normal chest expansion and resonance on percussion with normal vesicular breath sounds. Cardiovascular examination, she had warm peripheries with a refill time of less than 2 seconds and a point of maximum index in the fetal process case, mid-clavicular line. Heart sounds are too hard and normal. The skin was normal skin turgor and texture, no rashes, no ulcers, and no abnormal pigmentation. Endocrine, the thyroid gland was normal, not enlarged. She had normal hair distribution, no stria, and no acanthosis nigra. As to a skeletal exam, she had full range of motion in all joints, no deformities or muscle wasting, normal power and tone in all limbs.
No, it's okay. Yeah, thank you so much. So when our patient presented to us on the 5th of August this year, so we did a couple of investigations. But again, when the patient had been discharged, in that time, 2 weeks, when they were with us in the ward, we had already requested for some investigations, as you can see down in that list. But significantly on the CBC, the patient had a neutrophilic leukocytosis of up to 27,000, and it was mostly neutrophils. You can forgive me because the Mulago labs were not able to give us the absolute counts, but in terms of the percentage count, you can see it's 77. So anything above 70, ideally, you think that significantly that. So then in the HB, you can see the patient's HB was low, 6.9, and was a bit macrosomic. So you're thinking, what could be going on in this patient? Remember, this is a patient who already has a diagnosis of liver cirrhosis. So they have two things going on. They have chronic inflammation going on and also chronic liver inflammation going on. So the chronic liver inflammation could account to the reduced erythropoietin levels that are leading to this. That could be one school of thought. The other thought could be because of the chronic widespread inflammation. So we have a lot of interleukin-6 circulating, increased hepcidin levels, and that sort of like tries to trap iron in all the other body stores. So that could explain that. But again, what could be causing the macrosomia? Because that would be really iron deficiency kind of like picture. But in this case, we're seeing an MCV of 101.7 femtoliters and an MCH of 31. Ideally, that's more than 27. So what could be going on? Again, when you read further, they say that patients with liver cirrhosis like this one, most times have abnormalities in lipid cell membrane formation, call it. So that could attribute to the fact that this patient is getting is spilling out megaloblastic cells. Or also, because we're thinking still autoimmune, so there could be some element of autoimmune atrophic gastritis going on, and that could explain the malabsorption that could be happening in the GIT. Yeah. Okay. Okay, Prof. Yeah, so for the liver panel, you can see that the patient had severe hypoalbuminemia. Maybe that could be the reason why they were volume overloaded. I remember Pius asked about the RFTs, the hepatorenal syndrome type 1 for this patient. You can see that the creatinine levels are normal, but the urea is slightly high. That could be because of the dehydration. That was not an examination explaining that. So prior to this, we did a complete iron panel, and you can see that in patients with hemochromatosis, typically you'd find that they have elevated workups, but in this patient, they were really normal. That's why we thought that they didn't have hemochromatosis. Ceruloplasmin for copper abnormalities was also normal levels, ideally to be low in patients who you think are having Wilson's disease. So that was unremarkable. So what was significantly remarkable was the elevated anti-nuclear antibody and the anti-smooth muscle antibodies and IgG. And in patients who you think have autoimmune hepatitis, usually they have a very elevated asthma, which is said to be very highly sensitive in up to 90% of patients who you think have that. Then ANA, which is very specific, was also positive. So that's what we thought maybe. Could it be autoimmune hepatitis or still primary sclerosing cholangitis or even primary biliary cholangitis still in our picture? Okay, so we went ahead to do imaging. So MRCP, because of the R factor, which was typically less than 2, it was 0.9. So we're thinking, oh, does this patient have primary sclerosing cholangitis or primary biliary cholangitis? So specifically, the MRCP is the gold standard non-invasive test for patients who you think have primary sclerosing cholangitis. But as you can see there, it did not show us any features consistent or pathognomonic to primary sclerosing cholangitis, where you'd see a beaded kind of appearance in the MRCP. So it was really unremarkable. But also to mention, the MRCP is very poor in delineating the liver parenchyma. So, of course, you can see we put it in that color, liver cirrhosis, but you can't really trust it so much. You'd rather trust the triphasic CT abdomen, or even the abdominal ultrasound scan, or even better, the elastography if you have it. So the abdominal ultrasound scan revealed a massive splenomegaly of 22 centimeters. And again, that is consistent with portal hypertension. There was a mild hepatomegaly with preserved shape and echo pattern. So we're wondering, does this patient have macronodular liver cirrhosis? Because you can see the abdominal ultrasound scan is not really giving you those features of liver cirrhosis. But again, this is mostly seen in patients with metabolic associated liver steatohepatitis or patients with alcoholic liver disease in quotes. But again, this patient didn't fit into that. Triphasic CT scan, which would now help us to really see the liver parenchyma. You could see it could only pick out features of portal hypertension. That was splenomegaly, esophageal varices, and all that. But the liver was otherwise normal. So we went ahead. Now at this stage, our impression, because of the highly positive ANA, which is very specific for autoimmune hepatitis, coupled with anti-smooth muscle antibodies and the immunoglobulin G. So we're leaning more of autoimmune hepatitis in this patient, causing the decompensated liver cirrhosis. And that was complicated, as you saw from our findings, by grade 3 hepatic encephalopathy. So of course, the sepsis was still there because of the raising the WBC count, and the initial blood culture results were negative after 5 days. Okay, so just to, because as we see from that, the APRI score, again, just to strengthen our thought of autoimmune hepatitis, you can see this patient was started on steroids, initially given prednisolone from peripheral specialist center. You can see that the APRI score reduced from 4.38 until about 1.625. So could it be because of the steroids, or could it be because of the acidodeoxycholic acid? So at that stage, we're now confused between autoimmune hepatitis and the primary biliary cholangitis. So of course, ideally, you would think more of primary biliary cholangitis because it is a cholestatic liver pattern injury. But given the R factor of 0.9, but again, we have also seen case reports of patients with macronodular liver cirrhosis with no evidence of liver cirrhosis on your CT scan, abdominal ultrasound scan. Of course, we know issues about user dependence and all that. That's why at that stage, we were still with read further, and I sort of like gave you a case report that's not uncommon of a patient 61 years old with jaundice and cholelithiasis, but also had autoimmune hepatitis. So you could go through that, which is a bit consistent with ours.
Let's have a discussion at this point before we delve into the literature, because they have given us so much. We have had the physical exam findings, we have had the investigations, and I think our undergraduates need so much clarity at what is going on. So let's hear from Dr. Fahim, and we progress with the discussion. So actually, we shall start with the undergraduate up there, then Dr. Fahim, then Dr. Barunj.
And I also many acronyms.
Yeah.
Very short. This is also supposed to be
Learning.
You understand here.
Okay. Yeah, absolutely. So maybe for the acronyms, I talked about 2 acronyms. That's the R factor. So R factor is more like a scoring system that helps you to delineate what kind of liver injury your patient has. So for instance, if you did the R factor, which is typically gotten from, you get the patient's ALP divided by the upper limit of, ALT divided by the upper limit of ALT, divide by ALP over the upper limit of ALP. So any values less than 2 is consistent with cholestatic pattern of liver injury. So values between 2 to 5 is consistent with a mixed pattern of injury that is either hepatocellular or cholestatic. Then values above 5, which you would think in patients like the one we had with autoimmune hepatitis would be greater than 5. Then I talked about the APRI score. The APRI score is also another marker that is used to, especially very high sensitive patients with hepatitis C, because it was studied in patients with hepatitis C. So if you did the APRI score, it helps you to sort of like ascertain the level of liver fibrosis or the level of liver parenchymal changes in your patient. For instance, if you did the APRI score, especially if you got your patient's AST, over the upper limit of the AST, all that times 100, all that divided by the platelet count of the patient. If the APRI score is greater than 2, like for this patient, you think that there's significant liver cirrhosis. And you can be confident because the sensitivity in that is about 76%, though the specificity is a bit less, about 72%. Now, if you did your APRI score and it's less than 0.5, you think that, oh, your patient may not actually be having liver parenchymal injury consistent with liver fibrosis. So for this patient with an APRI score of less than 2, sorry, greater than 2, we think it was more of liver cirrhosis, even given the fact that our ultrasound scan, our abdominal CT scan were not really consistent with what we're doing.
Okay, just some clarity. Those asking questions, we want them to be very academic and informative so that the undergraduates can understand why we're asking. And we are running out of time because we have a lecture. So be very precise. We start with the undergraduate, then Dr. Fahim and Dr. Barunji, and then we shall progress to the teachers and try to conclude. Yes, please. A little louder. Louder.
Yeah. Absolutely. Yeah, so I'll start from the...
Excuse me, Regan, we shall have the questions first. Yes, Fahim and then Dr. Barunji.
Just a common often gets the lower border and it's about above border. They're supposed to get the liver span, and then that's when it's control. So it's just coming to the other words that you don't just get the lower border, get above border and then you get the liver span.
Yes, Dr. Barunji.
So saying this patient's short index. So and explain to another question.
Okay, we are going to have Dr. Senabulia answer the questions from exam, but let's hear from the teachers. I think there are some questions. Any questions from the teachers? No. Yeah,
It's a bit, yeah.
Okay, Dr. Senabulia.
Thank you very much. Maybe I'm going to start with the liver span. We forgot to note that on our examination findings, but the liver scan, we are going up to the 5th intercostal space on the right side. The shock index in this case would tell us if the patient needs to, if we need to act very fast. So it is
So it is about right over the systolic hypertension.
you guys, you can, it's something that you can calculate. We use the pulse rate over the systolic blood pressures, but it tells you when to act in case you need to take the patient to HDU and how often you need to monitor this patient, whether the patient needs ICU. So that is what we need, what you mean when you say shock index. Thank you very much.
Yes, absolutely. So, so just to say that the normal shock index should be 0.5 to 0.7. So if it goes above 0.7, you need to act. In an ideal setting, you want to activate HDU, those kind of discussions. But here, of course, we activated, but as you know, issues about space and all that. But any patient with shock index above 0.7, pious, you want to activate HDU discussions. Thank you. So like you said, it's pulse rate over the systolic blood pressure. And I think it's good for us to actually do it in our emergency settings. So I think, yes, you asked about a very good question about the T-colored urine. And of course, kudos to Prof, because Prof is the one who told us to make sure that that is asked. So because as you see, this patient has significant, or call it hyperbilirubinemia. So they were leaking most of the bilirubin in the urine. Okay. Yes, so that could explain the color of the urine then. But I remember Pius talked about issues about bile cast nephropathy and all the things, which could, of course, the color is not, you can't state, sometimes the color is dependent on who actually sees it. But again, our patient didn't have those typical features of kidney disease that you'd think in this kind of patient. Yes. Okay. Yes, but thank you so much for those questions. Then macrocytosis, Prof, you asked about it. So for this patient with liver cirrhosis, ideally, there's folate and vitamin B12 metabolic problems. So because they have liver cirrhosis, so the normal metabolism for folate and vitamin B12 is impeded. Probably that's why we are seeing microsomia here. But typically you see a mixed kind of picture of iron deficiency and folate and vitamin B12.
Okay, let's have the presenter wrap up in the next 2-3 minutes.
Okay. Yeah, thank you so much, Nelson, and thank you, everyone. So clinical issues on our day 1 and 2. So as you saw, patient had grade 3 hepatic encephalopathy. They had mild pruritus. They were hypotensive. So initially from the emergency, the BPs were holding up 111 over 64, but there was that decrease to 109 over 59. However, the MAP was still holding up above 65. Patient had significant hypoalbuminemia like we saw 16, and we're having issues of IV access on all of that. So we made a plan to insert an NG tube on this patient, get a central line support from ICU. A 3-throw catheter was inserted. We also took the blood cultures before we gave empirical therapy, as we shall see in a bit. HD consultation was activated, though it wasn't successful. So because of the significant hypokalemia that we saw in this patient of 2.0, we made a decision to start this patient on IV potassium chloride, 40 milliequivalents, albumin 1 gram, high dose because of the significant hypoalbuminemia. Because this patient was previously in the hospital, so we're thinking more of hospital-acquired spontaneous bacterial peritonitis. And studies have shown that patients who have had, who you think have hospital-acquired SBP, the drug of choice is PISA. That's why we started this patient on IV PISA. Of course, we gave IDT-10 because she wasn't feeling so well, IV omeprazole, stress ulcers and all that, lactulose because of our grade 3 hepatic encephalopathy and oral rifaximin. Now, because we're thinking more of autoimmune hepatitis with the flare, now we're seeing the BPs going down and all that. So we pulse this patient with IV methylprednisolone, and studies strongly support that. You pulse them for 3 days before you go down to the conventional therapy, so prednisolone. That's why we gave that. But again, we're still contesting, is it autoimmune hepatitis or is it primary biliary cholangitis? That's why we gave the ursodeoxycholic acid or acetadiol to help with that. Of course, the itching, that's why we gave cholestyramine. Vitamin K, because we're thinking more of, it's macrosomic liver cirrhosis, but there's some element of cholestatic liver cirrhosis we think through. That's why we gave vitamin K, 5 to 10 milligrams for 3 days, and studies actually support that. Okay, so day 3 and 4, you can see the vital trending. Because maybe of our interventions, the pulsing, you can see the BPs went up. The systolic was ranging between 126 to 154, and diastolic was 62 to 92. Heart rate was getting a bit crazy, borderline, it was 100. SpO2 came down a bit. That's a bit, because from the emergency, patient was about 98 to 100. So 93%, we're wondering what's happening. What could be the problem? CA19-9 was a bit high. So we're wondering what could be causing an elevated CA19-9, and especially given the fact that the MRCP was very uneventful in terms of the pancreatic pathology, because patients with elevated CA19-9 typically have your pancreatic malignancy. But this patient, what could be happening? Again, we read further, and it has been shown that patients with liver cirrhosis actually, because CA19-9, much as it's made from the biliary tree, still has to be excreted from the hepatocytes. So if you have liver cirrhosis, there's going to be impediment of that excretion. So that's why we thought maybe that could explain the elevated CA19-9. PTINR, like you see, was prolonged, which is consistent with our thought process. Blood cultures, again, were negative. The CBC, surprisingly, you see, it reduced from 27.21 to just 27.12. So we're wondering what could be happening. There's persistent leukocytosis, despite the fact that the HP improved by about 1.5 grams per deciliter with 1 unit of transfusion. Peripheral blood film was unremarkable. Urinalysis, probably because of our steroids or ursodeoxycholic acid, you see that the bilirubin levels reduced from 3+ to 2+. So probably thinking that way. So day 3, day 4, we had, of course, major issues. Patient became very dyspneic. The respiratory rate was 28 cycles per minute. They became semi-conscious. Remember, they came in with a GCS of 12/15. Now we are going down to 8/15. Patient became very hypotensive despite all the interventions we were doing. So now we set the patient on vasopressor support. So we did a thorough examination of the chest, and we revealed a hyperresonant percussion note on the right hemithorax. Remember, this was on a background of central line insertion a day prior to this. So could it be iatrogenic from the central line that we're having a hyperresonant percussion note? Chest X-ray was requested, and we activated consultation with CTS surgery. And of course, before they came, we started the patient on oxygen therapy. It was holding up to 88 at the very lowest. We put a right tube thoracostomy, and that continues the rest of the plan. So antibiotics were switched because of the persistent neutrophilic leukocytosis from IV PISA, which is guideline recommended, to IV meropenem, which could be better. I mean, yeah, if you think through it, we transfuse the patient with 1 more unit of blood and maintain the rest of the plan. Now, at this stage, we had already switched the patient from the pulsing of IV methylprednisolone to the standard therapy of prednisolone, 1 milligram per kg per day. That is, to practicalize it to our case, it was 40 milligrams BD. Unfortunately, our patient continued to progress to grade 4 hepatic encephalopathy, remained on vasopressor support despite noradrenaline. She later on in the day developed copious secretions, became very feverish, with cause crepitation still on the right lower limb. So could it be a pneumonia on the tension pneumothorax that was probably iatrogenically caused? So unfortunately, at about 6:30, patient got a gasping episode, and despite all our resuscitated efforts, she passed away. So our final clinical cause was maybe, could it be decompensated liver cirrhosis secondary to autoimmune hepatitis, or could it be autoimmune hepatitis, primary biliary cholangitis complicated by this grade 4 hepatic encephalopathy, sepsis, hypotension, and the iatrogenic right pneumothorax post central line insertion? So I think that one person will ask, why didn't you start this patient on other theoprene? Because the current guidelines, the American Association and the European Association of Study for Liver Diseases recommend against using steroids for a short time. So I think for our case, we didn't have enough time to actually reduce the dose of steroids and bring in the other theoprene. And also, could it still primary biliary cholangitis? Again, despite the fact that we saw that AMA, which is the antimitochondrial antibody, which is very sensitive in patients with primary biliary cholangitis, was negative. Still, you can go ahead to do ANA, especially antibodies, anti-SP100 and anti-GP120. So those patients who have AMA negative primary biliary cholangitis, if you found anti-SP100 and anti-GP120, probably it could help us, but we didn't have a long time, we didn't have enough time.
Thank you so much, Regan, for the discussion. I know there are so many questions, but we are running out of time. We are going to invite the teachers, and we shall continue pondering about the case. So let me invite Dr. Namukwaya, who will be followed by Professor Chama, and then the mini round patron, and finally the head of department. So I invite you, Dr. Namukwaya. Thank you.
Morning, everyone. Thank you, our team, for the good presentations. I'm going to give some brief comments. So in this patient who came in and had liver cirrhosis, which was decompensated, and the etiology was not known, we had done, before they came to the hospital here, the virus screen was negative. Had no features to suggest of metabolic associated liver disease. So the thing we thought of autoimmune hepatitis, being that this is a female and it's common in females. So just to remind you that when you have a patient with liver cirrhosis, remember autoimmune hepatitis, especially if the virus screen is negative, although they can coexist also. So autoimmune hepatitis has a wide spectrum of presentation. You can